Good morning, good afternoon, and good evening. Welcome to the Olea Academy Educational Series. My name is Dr. Adam Davis, and I am the Chief Medical Officer at Olea Medical. Today, it gives me great pleasure to introduce to the audience our speaker, Dr. David Liebeskind. Dr. Liebeskind is the Professor of Neurology at the University of California, Los Angeles, where he has practiced, taught, and conducted research since 2004. Dr. Liebeskind received his Bachelor of Science in Chemical Engineering from Columbia University in New York City, and then attended medical school at New York University. He did postgraduate residency and fellowship training in neurology at UCLA. He was briefly a member of the faculty at my alma mater, the University of Pennsylvania, before returning to UCLA. Dr. Liebeskind is the director of the outpatient stroke and neurovascular programs at UCLA. He is the director of the Cerebral Blood Flow Laboratory, associate director of the UCLA Stroke Center, and he is most importantly responsible for training the residents and fellows in cerebrovascular disease. Although a neurologist, Dr. Liebeskind is as familiar and as expert in neuroimaging as any radiologist that I know, maybe even more so. Dr. Liebeskind is responsible for the neurovascular imaging research core at UCLA, and as a result, he has participated in many of the landmark stroke studies conducted over the past decade. He is a central figure in the evolution of neuroimaging for the detection and analysis of acute ischemic stroke, and he is one of the leading investigators in the understanding of cerebral collateral circulation. Personally, I first met David approximately 10 years ago when he was a visiting professor at New York University. I found him to be an engaging speaker and an insightful clinician, and most importantly, a very pleasant and gracious person. I'm very pleased he has made the time to contribute to the Olea Medical Education Series. Today, Dr. Liebeskind will be speaking on imaging of acute ischemic stroke. For the audience, should you have any questions during the lecture, please type them into the chat box, and should time permit, following the lecture, we'll allow Dr. Liebeskind to address any of these questions. And now, without any further delay, I turn it over to Dr. David Liebeskind.
Well, thank you very much, Adam, for that wonderful introduction. These are some of my roles. I'm the director of the UCLA Stroke Center and also president of SVIN, or Society of Vascular and Interventional Neurology. But I'm speaking to you today about imaging of acute ischemic stroke. Adam, you can see my slides?
Yes, I can. We're good to go.
Okay, wonderful. And a little bit in depth about how we're using imaging on a routine basis, not just in trials, but also in terms of daily practice. And a lot of this has a lot more to do with the way we're interpreting the information and handling the data in terms of the decision making in real time. So I'm going to provide an overview of the current imaging modalities and strategies. I'll say that this has not changed very much in the last decade or so with advanced imaging, with multimodal CT and MRI. Of course, we do have transcranial Doppler and angiography, which is increasingly important with the evolution of endovascular therapy. I speak from the standpoint, or from the simple model of an M1 occlusion, to speak to a lot of different scenarios of real-world stroke care, where we deal with distal lesions, stenoses, and all kinds of other combinations of lesions. I'll provide some case examples as a snapshot of what we do in terms of acute stroke imaging and perfusion as well. So we move from an ideal situation to the real-world situation. Then this has a lot to do with evolution of precision medicine, and it applies tremendously in terms of imaging and acute ischemic stroke. There is a math analogy that that when we ask, what do we get from the imaging, there are certain variables that are commonly defined: ischemic core size or penumbral extent. And mathematically we can think about this as an X and a Y, simple variables. One of the issues that comes up, though, is that there are different definitions of how we get to that X or Y metric, whether we're using one modality, whether it's CT or MRI, whether it's with CBF thresholds or Tmax thresholds, and what those thresholds are, and what cut points do we use. And of course, the more complex the equation becomes, perhaps it becomes a little bit more refined. But the whole goal is to figure out how all these variables determine the outcome. Now, all of this, of course, when we talk about acute stroke imaging and prediction models, these are probabilistic estimates. These are guesses as to what is most likely to occur, but obviously no guarantees. And there are no conditional terms. These are direct calculations. There are no ifs, ors, or ands. If you do this, or if you stop short during endovascular therapy, or you apply one treatment or another, the implications are very different in terms of what happens in terms of prediction of that imaging pattern. So you get to very complex equations in this analogy, and this is one approach that's been used. The other approach that's been used is what you've seen in the last several years, which is sort of the AI approach. And I'll speak a little bit more about this in general, because this has not so much to do with artificial intelligence per se, but a lot of what's being used in practice is automated imaging. And those two are very different, and their performance is different. So in terms of imaging selection for thrombolysis and thrombectomy, for a number of years now, there's been consensus, I think. We used to debate this for many years, but I think there's definitely consensus. You use what you have available, and you hone in your expertise. So the way I like to put this is you use what you own, and you own what you use, meaning you own up to those imaging determinations and decisions that you had based on the imaging at the time. Imaging modalities, each one will offer a different perspective. So the question is not relevant as to whether you could do pH imaging of acute ischemia in the setting of stroke. You can, if you had that available to you, and it can provide a tremendous amount of information. Now, whether you need it or not is a separate question. And probably the most recent iteration or change in this consensus, however, is how we select patients. And one can argue that selection of patients is outdated when you ask, so what are you doing this diagnostic study for? What are you selecting them for? Are you selecting them for non-treatment? This is no longer as much of a question with endovascular therapy. Now, of course, there's disparities, and we hear a lot about this in terms of the resources that we have available to treat stroke, whether it's in the diagnostic or in terms of the treatment resources that we have available. There's disparities in terms of recognition and in terms of healthcare availability as well. But there's also disparities in terms of not just the resources and the tools that we have available, but the expertise. And this is something that develops over time with practice, and it matters tremendously. Ultimately, it's the diagnostic confidence that's paramount, but this sometimes varies. So you'll see sites that'll do CT followed by MRI still to this day in the setting of acute ischemic stroke. And what this says is that their diagnostic confidence in the CT may not be up to snuff, because otherwise you would never go to a second imaging study. So how do we use imaging? Imaging is used as a component of the clinical evaluation. It's truly an extension of the clinical evaluation. It's in a way part of the history and physical examination in a modern light. It's not separate or distinct. We don't evaluate patients clinically and then separately go on to then do imaging to separately make a diagnosis in an isolated environment. But this isolation concept has to be considered, I think, in many different ways. In the two principal directions, in that it's difficult to interpret an image without the clinical information, and it's difficult to figure out what's going on clinically without the imaging. The two go together, and one cannot be done in isolation. Imaging strategies are support tools. So everything that I mentioned in terms of these tools, these are support tools to help you diagnose and properly treat in the most rapid time frame possible. But there has been an oversimplification of stroke. So as I showed you a few slides ago, the calculations about imaging models can be extremely complex with a lot of different particular aspects and exceptions to the rule. But at the same time, over the last decade or so, we've, as a group, attempted to simplify stroke, to put stroke protocols in place, pipelines, guidelines, consensus statements, that are useful as general tools, but they're not a guaranteed recipe for successful outcomes by any means. Acute ischemic stroke pathophysiology is itself highly complex and individualized based on examples such as collateral circulation. I mentioned that expertise matters and what you're doing, and that diagnostic confidence matters. Giving the same tools to different individuals does not work out the same way. And often in this paradigm, people have attempted to make stroke as simple as possible to reduce it to the least common denominator. What is the most basic approach you need to take? Can we do a non-contrast CT alone? An answer to that is yes. It depends on what information you personally are extracting and how fast you're making that decision. So you can do a lot of different things with imaging. It's not the same for everyone. So multimodal CT, as I mentioned, is a component of tissue imaging with non-contrast CT, CT angiography, whether in one variation or another, as I'll get into, or CT perfusion. And this has been around for at least 20 years now. We've been using CT perfusion since the late 90s and CT angiography since the mid to late 90s. And the only thing that's changed is it's become more routine and widely available. We've been doing this with the various maps on diffusion, flare, gradient, echo, MRA, and perfusion on MRI for many, many years now, actually for longer. So we've been doing this since the middle of the 1990s, for almost a quarter of a century now. And oddly enough, using the same imaging acquisition. So the acquisition of imaging with CT and MRI has not changed for 25 years. But imaging is sometimes imagining. As I mentioned, these definitions of what we're defining as penumbra and core, perhaps they're not so rigidly placed or defined. The volumes of these threshold parameters matter. The modalities depict different facets as well. So CTA is not the same as MRA. This is true both in the setting of stenosis and as well as their ability to really illustrate collateral circulation. When it comes down to post-processing and the calculation of maps and automated maps, there is this issue about the secret sauce. So the computations are not, open source for everybody to develop and further develop. So there are bits and pieces that are specific to the calculations. Finally, aspects. This is when done as a basic parameter of core size or perceived core size or ischemic change on CT or MRI. This, in manual fashion, is in a way a Rorschach test of acute stroke imaging. Many years ago now, at a meeting, the cases of acute stroke imaging were shown on CT, and the aspects ratings by a group was shown to vary from 2 to 10. So a lot of differences in terms of how people are applying aspect scores. There's also a difference in terms of whether we use one measure or another to determine core. This has been an area of debate with acute stroke imaging for a number of years now. The first set of images above show an aspect 7, CTP core of 0, and this is because of a fluctuating cerebral blood volume. So the aspect is not normal. On CT, you see the equivalent with a diffusion done contemporaneously, but there is no core based on the CTP definition that was used. And that's because what's happening is that blood volume is going up and down. On the other hand, the same aspects level of a 7 can be seen with a core of 45, again with a fluctuating cerebral blood volume. So the CBF, or the core size that you measure of less than 30%, which is the standard measure compared to the contralateral hemisphere, will vary depending on the exact moment that you image that patient. So if you've recanalized that region, but you've already infarcted, then your core, with that measure, your CBF may have returned to normal. On the other hand, if the core drops very, very early, and then only occurs for a short amount of time, the aspects, the ischemic injury is not going to evolve at the same pace. So there's differences in terms of these definitions. So precision medicine is about finding out what's right for the right patient at the right time, in doing all the right things, so to speak. And imaging is an excellent way of measuring the phenotype of acute ischemic stroke from one patient to the next. And each patient's a little different, and we see this when it comes down to the evolution of endovascular stroke therapy and how different scenarios apply. There are almost no two stroke cases that look identical from an imaging standpoint. So coming back to this issue about therapy and how do we select for therapy? Well, in the early days with thrombolysis alone, with TPA, we didn't need anything. It's hardly selective. You don't need to see anything. You don't need to see ischemia, and the only question, the sole diagnostic question, is whether there's hemorrhage on a scan and nothing else. In endovascular therapy, this is almost the opposite. It is intuitively selective. That we're looking for a large vessel occlusion that can be treated with endovascular therapy. But there are a lot of variables that come into play. The timing of the imaging, infarct size, penumbral pattern, occlusion site, and this has evolved and is evolving right now in terms of different trials that are ongoing in terms of whether we can go after and treat certain patients a certain way. But endovascular therapy is always about imaging. There's no way you're going to take a patient to the angiography suite without imaging. Angiography itself is imaging. And even if you're reducing it down to a flat panel CT in the angio unit, you're still going to be doing imaging. So you have imaging before, you have imaging during the therapy, and you are always going to have imaging done afterwards, at least at the 24-hour time point. And when we look at the imaging and the angiography, there's a lot that can be seen angiographically. And the course of how someone revascularizes or their TICI score is reperfused varies from patient to patient. And this is an entire saga in terms of what happens in the angiography suite that, of course, is determined by the decisions, how far to go, when to stop, what is right in one patient from one to the next. To this moment, the decision-making is sort of not on the main stage in terms of the angiography suite of endovascular therapy. This is something that is still elusive. We're still focused on the baseline imaging and the go, no-go decision to just get to the suite, but very important. So in terms of diagnosis, clinical localization is distinct from imaging. They're not always the same. And it the counterpart to that is that imaging is not just the isolated answer, so to speak, because you can find lesions, but it has to match what the clinical indication or the need is. So the clinical and imaging portions are done in tandem. One is done shortly after the other, and sometimes we reevaluate with both clinical or imaging approaches, but one is not done without the other. So how do we use imaging? Imaging is the central focus of most acute ischemic stroke trials. The days of non-specific IVTPA use, seeing nothing on CT, are in the past. Now we do have targets in terms of what we're looking for on the imaging. So in terms of recent trials and older trials, size, the timing, whether early versus late, proximal versus distal occlusions, is an evolving story that's of great interest right now, and a big problem in terms of what the best way of measuring the various facets are. And of course, as I mentioned, in terms of aspects or ischemic change versus blood flow, in terms of core or lesion size up front. On the other hand, there are those that will advocate skipping all imaging, that we should just move ahead and make decisions without the imaging. And some have argued that the imaging is lying to them, and they haven't learned anything different from the imaging, that occurs. And I would argue that's not true. We always have more information. And I would also argue that if someone truly believes that they never get any further information, or it never helps to get the imaging, then they shouldn't. Then they shouldn't be getting imaging. They should just move ahead and practice however they feel best. So timely information is important. So this has to be done in real time. And this has been really the impetus to automate and the explosion of AI approaches. There's been a lot of questions about whether AI needs to be proven or not. One can argue that the machine learning, so to speak, of AI is what we do of our individual brains when we look at imaging studies. But how do we do this and how do we refine it in a standard fashion? So there are a number of vendors out there, as you know. Rapid via Schema View. Their focus has for a while been on the ultimate definition of core penumbra. But one of the issues is that it's dynamic and it's never reproven in the same case. So it's an estimate. So it's not proven per se and not a guarantee. And of course, with each paradigm or set of stenosis or occlusions and lesion sites, it's going to vary. Viz.ai and others have automated things and have been much more behind the approach of automated alerts that AI is a tool to accelerate the routine processes that we have and not to replace per se. But what are the targets? Are we looking for a large vessel occlusion, whether proximal or distal? Are we looking for core size or a specific perfusion parameter? And a lot of these questions have been approached differently by different vendors. So what are the limitations? The limitations are that it's all contextual. It all depends on whether it's acute or later timing. How do you do this without any clinical information, with no history? You can absolutely improve these models with a little bit of clinical information. What about the lesion itself in different stroke subtypes, in non-cardioembolic lesions where you have a stenosis? What about with bilateral lesions? And what happens if the information is not being used at that moment? These are snapshots in time. And we are making a lot of assumptions that the second that you have a result, that it's going to be used at that moment and interpreted that way. If there's one simple conclusion I can make about, whether imaging is important in acute ischemic stroke, should we get CTP or perfusion weighted imaging? Well, it is about perfusion in ischemia, in acute ischemic stroke, and reperfusion is the goal. So absolutely, I would perfuse and I would obtain perfusion studies. Now, of course, it has to do with whether you individually are going to use it and it's going to be useful and not just giving it or making these recommendations to others. So shifting to show you some examples, I've spoken a lot, but not shown you as many images. A lot evolved from this concept of mismatch. And there are a lot of different mismatch approaches, mismatch between, diffusion, perfusion. In this case, you have to be very specific. This is the mismatch between an ADC signature of less than 620 versus perfusion. But as you see, there is a diffusion lesion. It's just not less than 620. And there is a perfusion lesion as well. So there's a large mismatch, although this one would be calculated in an automated fashion as a mismatch of 0 based on those definitions. The mismatch also varies depending on what threshold you're using for Tmax. Tmax 6 is what has been used standardly, but you can use other parameters. And there's nobody that's ever proven that the Tmax 6 lesion works in distal lesions or in stenoses or in other settings, and that's simply because it actually doesn't. So Tmax, we have certain parameters, thresholds that we use, and we see that that obviously there's a delay. So there is a Tmax delay, but how severe is it is a question. And this is most commonly seen in the setting of stenoses. And with shorter delays, we've assumed that if they're below 6, that they're non-consequential, and that may not be the case. Showing you here what happens after reperfusion. Yes, the most severe areas where you have that perfusion delay are the areas that go on to then evolve towards more severe ischemia, even after reperfusion. So what do we do about cases like this? And I'm sorry if these are playing a little bit too fast, but some very basic imaging that, depending on how fast you look at it, may seem normal. Now, with the trained eye, we should be able to look at imaging, not in automated fashion, but with an operator or individual. And people have put the estimates that an aspect should be read with CTA and an interpretation of the CTP within less than 30 seconds. That may seem ridiculous, but actually it works pretty well. When you look at the CT, and looking at things from the standpoint of an aspects standpoint in terms of a tool, there is an algorithm that's used that can show you this right MCA lesion very, very clearly. This is a large early set of ischemic change in that right MCA field. It's helped by the fact that there's a hyperdense MCA that's seen right there, but the lentiform insular region, even the M2 region are abnormal at this stage, and perhaps some others. CTA, shown here, shows you what we see is that equivalent of that M1 occlusion. I just want to see if I can scroll this back to the point, to make this point, that the hyperdense MCA sign is a great sign. It is not the sign of the occlusion. It is stasis due to red cell-rich thrombus, proximal or distal to the occlusion. And you see this beautifully defined here, where the occlusion is in the distal M1, right at the M1, M2 junction, and not where you see that hyperdense MCA sign more proximally. And the only way that's figured out is by looking at a lot of images and comparing one with the other. The CTP shown here, all you're looking for, basically, I would argue, is a perfusion abnormality in terms of that delay. Because you're expecting to see an occlusion. Exactly how severe this perfusion lesion is doesn't matter, I think, whether you're in one time frame or another anymore. So it's just the presence of a perfusion abnormality. And as I'll show you in some other examples, with distal occlusions now as a target, it's the CTP that's being used just to see whether there's a pattern of an abnormality downstream, not the threshold. As a better way of finding a distal occlusion and not actually using your CTA. CTA recognition of distal occlusions, whether in an automated fashion or through individual operators or interpreters, is abysmal. It's horrible. The inter-rater reliability is piss poor. But what you're looking for is the perfusion abnormality that's associated with that distal lesion, and that can be easily seen on a perfusion study. So in a way, we're using perfusion for different reasons. We'll skip over that and just show you that in the same case, again and again, what you see is angiographically is what you see from a non-invasive standpoint. Showing you the lateral projection here. And in terms of what evolves. So not a good outcome. And why? One can argue it has a lot to do with patient-related factors. It has to do with timing, perhaps. One could argue it has to do with the imaging. This area was abnormal at baseline. So will large core based on aspects determine who does well or who does badly? It may determine the overall course. Obviously, if you have more ischemic change at baseline, then you're not going to do as well in terms of subsequent stages. That does not mean that you should not treat with endovascular therapy, which is a separate question that must be considered. I'm going to skip over this to go on to a further case. So what about really, really early? We're used to seeing nothing on CT. And this is the problem, is that people look at the aspects here and they'll say, well, I'm not seeing very much. Well, it depends on whether you are looking for an answer or not, right? So there are early ischemic changes here that are seen. They're subtle, and this is a very simple way of looking at aspects. This is just comparing it to the contralateral hemisphere. The earliest way this was looked at was actually with an insular ribbon score published now several decades ago. It was a regional assessment of CT, some very basic findings in terms of the regions that tend to be abnormal up front because of their distal reach or the furthest reach from collateral circulation when you have a proximal MCA occlusion. But really, really early, you see this pattern. So there's some aspect change and a huge lesion. But one of the problems is, as I mentioned, if the CBF less than 30% is already this size, there's some people that would look at this map and say, oh, do not treat this patient. And there are a lot of questions that then follow. The CT does show some early ischemic change, probably about an aspects of 7 or so, which is not prohibitive by any means in terms of treatment. And you have this pattern. The pattern where you have a perfusion abnormality associated with a large amount of penumbra, but unfortunately, based on this assessment, a large amount of core. So the timing here matters. It depends on whether this is 1 hour or much later. Now, this looks very, very bad. But some of the questions that come up as to whether you should treat this patient or not with left M1 occlusion is, what else are you going to do if not doing endovascular therapy? The other question is, why do they look so bad early? And this has a lot to do with collateral circulation. It's the flow that's seen, you can see angiographically. You see this proximal M1 occlusion, and you see very, very little in terms of collateral circulation coming in. This is why you have this delay. This is why you have this low CBF. It's all delivered via collaterals, and the collaterals look poor very early on in this case. So what happens in this setting? So it may be early. This will play out. And we do have the ability to reperfuse. And you can get to a full TICI reperfusion. But the consequences are the real question. So this is what happens in terms of reperfusion. You see some accelerated perfusion with some delay, which tells you on the post study that you have reperfused some ischemic areas. So what occurs downstream in terms of the field? You're early and you have a low amount of blood flow, and imaging here perhaps told you not to go. Others would argue that the aspects wasn't that bad up front, but obviously the lesion size and the hemorrhagic transformation of an HI2 are pretty bad. What about in milder cases, so to speak, milder based on the imaging pattern, so to speak? We see this very commonly, a little bit of flare vascular hyperintensity, no diffusion change, and you see this abnormality, TTP, that for many years was instantly available to scanner, and you'd say, well, there's nothing there. Well, if you look close, you can see that there is an MCA, a left MCA abnormality. Now, if you do the computation and you look at the Tmax, the Tmax shows in the colorized image, of course, which is very similar in parameter estimate to the TTP, the very clear abnormality. Now, you may say, well, it's not that severe in terms of the degree. True. But the questions here are a little bit different. So what are you going to do about these, about such cases? Because it's mild, should we not be treating? Or could we argue that perhaps we're going to get a better outcome than in the last case that I showed you? Well, if you use the Tmax of 4 threshold, you'll see that there is a large area of penumbra. If your only definition of penumbra is a Tmax 6, then there is 0 penumbra and nothing to be done. A very similar lesion, a distal MCA lesion, shown here on MRA, and actually TCD parameters that were acquired show here that the left MCA is open, but with a high degree of high velocity and decreased pulsatility, meaning that vessel is wide open downstream, distal to it, and a signature of a stenosis. So what do we do? Is that stenosis due to thrombus, thrombotic occlusion, incomplete occlusion, or is it due to athero? And should we treat it at all? Should we treat it with thrombectomy? It's an open question. So Here you see, what happens in terms of subsequent CT. Those early ischemic changes on CT show up here later, and that's always the case. That you see here a mild abnormality, a Tmax 4, Tmax 6, but Tmax 4 abnormality that's far greater. So the perfusion abnormality is far greater than what we use in terms of the determination to treat an acute ischemic stroke due to a presumed complete occlusion of an MCA. So a stenosis is very different than complete occlusion. One is very, very different than the next. And we still don't have the answer as to what the best approach is for this because we assume everything is an occlusion and we don't treat. Now, one of the problems is that if you don't treat, this doesn't mean that they have a fate that is somewhat different. This does go on to infarction. This is something I would not want in my brain, so to speak, which is ischemic injury in my left hemisphere with a perfusion abnormality. I'm just going to go to this case and then end with some slides so we have time for questions. Some of the mildest cases are the most difficult. It's the non-obvious cases that you need the assisted imaging with. Here you have a lesion, a high-grade stenosis of the basilar, but other lesions as well. Now, of course, your question from an imaging standpoint depends on what the clinical question is. What is it? What are you suspecting? And of course, we always think about going to the imaging and looking for one answer, and it's not always the case. So you wind up with, especially with patients with intracranial athero or other atherosclerotic lesions, they have more than one lesion, and you can see perfusion abnormalities. Sorry if that ran by a little bit too quickly, but you can see perfusion abnormalities with other non-symptomatic or the non-acute lesion per se, and there's simultaneous lesions that occur as well. And we oddly go at this in a funny way. We assume that the patient's only going to have one lesion, and that's not necessarily the case. That basilar can be treated, but the other abnormalities may persist. So I'm going to skip over this to get to some final slides here towards the very end, and that we have time for questions. There are enormous sets of examples. Almost, as I mentioned, almost every single case is different in acute ischemic stroke imaging in particular, and each one is more fascinating than the next. I apologize. I thought I had a couple of more slides here at the end in summary, but I think I excluded them. So I'm going to stop there and take any questions that arise. And thank you again, Adam, and everybody convening this webinar.
Thank you, Dr. Liebeskind. That was excellent. That lecture was truly, truly excellent. I often say that the best lectures take messy, difficult, complicated concepts and they categorize them and make them apparent for the audience, and you certainly accomplished that. Thank you. We have several questions from the audience. You certainly piqued some interest. I'd like to start with a few. I'm going to try to start with broader questions with a little bit more applicability to a broad audience. You touched on the need for imaging, and you discussed that very graciously, that the individual practice of the doctor who is evaluating the patient and doing the endovascular therapy is very important. What is their experience? What is their expertise? So the difficult question is, some people believe that in less than 3 hours from the onset of acute stroke, no imaging is necessary other than a non-contrast CT to rule out hemorrhage, and that the patient should have the benefit of endovascular therapy if a large vessel occlusion can be documented. But it also raises the possibility that this may be a futile endeavor and that there is no salvageable tissue. Can you comment on that? as well as the patient that presents from 3 hours to 6 hours or even beyond 6 hours?
Yeah, so part of the problem is that stroke is everywhere, so to speak. Each stroke patient is a little different. As I mentioned, the pattern on imaging is a little different. The resources you have available and the treating physician are different. So prescribing, so to speak, the right recipe, the same recipe for every patient is never going to work. So when it comes down to the decision making, doesn't stop at the time of the decision to go to endovascular therapy or not. Endovascular therapy is not a black box, so to speak. It's not, you go and you do it and it's done and it goes perfectly. There's no surgeon in the world that would claim that everything is that every surgery is identical and goes perfectly. The most perfect surgery of any kind should only take X number of minutes with no complications. But that's not always the case. And it's the same thing for endovascular therapy. There's a lot of decision making that I alluded to that takes place during the study. Now, one of the problems that you have with that is that the baseline imaging is done before the endovascular therapy, and it provides a lot of information. So even if it's not about the question about going forward with endovascular therapy or not, you're still using that information in the angiography suite. Very commonly, it's that recollection of what the baseline imaging pattern is that will influence how far to go in terms of whether you're going to revascularize that more distal lesion or not, or when to stop. So the approach of endovascular therapy itself will vary a lot depending on what that baseline imaging looks like. And then, of course, it's still an evolving area, but imaging in the angiography suite that changes. But when it comes down to the early imaging and the decision to go to endovascular therapy, do you need anything? Well, it depends on who. Can you take the average patient, shortly after onset within the first several hours, or alternatively, can we make a rule that we take all patients at our own facility within 3 hours or whatever time point you want to use early to be used or defined as, and we do the most basic imaging and take everybody to the angiography suite to treat. Yeah, we can do that, and overall for the group, it may not be wrong. Are you going to get the best results? Not in all cases, and are you going to be able to explain why some patients do worse than others? No, without the imaging, no, you will not. So the imaging helps in terms of prognostication, in terms of both the treatment all along the way, in terms of the angiography suite, in terms of endovascular therapy, as well as prognostication, which is very important. And I should argue that it doesn't stop there. It also, continues to evolve in terms of what happens in the ICU, the common location these patients are treated in for the next 24 hours. People have similar questions about acute stroke imaging, and the focus is on the post-procedure or not the baseline, but the follow-up imaging study. And that's an open question, when it comes down to things such as blood pressure management in the ICU, hemodynamic management, even after reperfusion. Reperfusion is not perfect, in endovascular therapy, and how high that pressure should be, or if you didn't intervene, if you have a stenosis, where to maintain the blood flow levels. It's completely unclear. Now, imaging can be used for that reason, and to see whether you have sustained blood flow and prevented further ischemia or not. And also, even when it comes down to hemorrhagic transformation in acute ischemic stroke has been poorly understood. It's been poorly understood because we assume that everything is a big bad hemorrhage. And conceptually, the problem with that is that initial imaging of the stroke patient, whether ischemic or hemorrhagic, has sort of been dichotomized and divided as such. And acute hemorrhage will present as an intraparenchymal hematoma. But with kind of stayed around that idea and focused on that idea that everything is an ICH, is an intracranial or intraparenchymal hemorrhage, a parenchymal hematoma. And that's not true in ischemia. The hemorrhages that occur, almost all hemorrhages that occur, are hemorrhagic infarction type 2. They're hemorrhagic conversion of ischemic infarcts, which can be bad, but they're not these parenchymal hematomas per se. They're petechial. So even when it comes down to the hemorrhage after that acute decision in the treatment, understanding how to use imaging is still a nuanced facet or aspect of stroke care. And one example I can throw out here is, very commonly people will want to image and go to imaging immediately after being in the angiography suite. That's a recipe for disaster, because you're going to find what looks like hemorrhage or contrast almost always, and you're not going to know what to do with it. So again, it's not, the imaging isn't lying, it's not wrong, it's not telling you incorrect information. The imaging provides information. Secondarily, what you do with that information and how you determine, whether that's important or not, and your decision making is really the most important aspect.
Thank you. You touched upon so many interesting subjects. I wish we had an hour to discuss them. You discussed the need or the role of imaging post thrombolysis, post thrombectomy, to help guide the post reperfusion time period, and that in itself is a fascinating subject, one that needs much more investigation. You also touched upon hemorrhagic conversion, something that we're not very good at in terms of predicting or understanding, how far can we push that envelope, accepting the risk of petechial hemorrhagic conversion, but still benefiting the patient. Really fascinating concepts. We're going to have to wrap up soon. I'm going to try to get in a couple of, we have a lot of questions. I'm going to try to get a few more in very quickly.
Sure.
Someone asks, does it matter what type of software you're using for your perfusion post-processing?
Yes and no. It depends. It depends on, what's in the black box of the software. The secret sauce, as I mentioned, matters a whole lot. The one caution I would make is I would be very, very careful of what has been rolled out in terms of routine practice. So, people, have gone with the idea that immediate results are best because they're as fast as possible. I can tell you that, so what's happened is, in terms of some of those products, they receive FDA approval for one component and not everything else. And they deliver those without warnings and without labels on the images that these are, that user beware. And particularly with aspects, I would say that there are some software programs that for automated aspects are probably correct in the total number of the aspects, maybe 15 or 20% of the time. Now, by example, obviously, if you flip a coin, you'll be right, probably on about 50% of the time. So you're better off flipping a coin than using that tool. Wrong hemisphere, wrong lesion location, completely wrong. That's completely insufficient. So does the software matter? It does matter. And what I would argue is it depends on what you're doing with that information. So what nobody will speak about is people will say that the people that use these tools in routine clinical practice use them, but what they'll tell you is, I like having that tool available, but no, I'm not really going to look at that, that automated result. I know how to further interpret that. And that's very useful. And it also, has, these automated approaches have very interesting implications in terms of training future physicians. I'm a little bit dismayed because I've realized that recently radiology trainees around the world in several different countries now are training to read aspects because this has not been standard in the past, but they're training off of automated software and not necessarily looking at the software and then looking at the images by themselves, but just off the automated maps. And what I will often say is that that's not reading, that's not learning. You're just taking the result that an automated software program gives you and moving with it. And I think that's to be problematic in terms of how those people are going to perform in future years.
Thank you. We agree, at Olea, we agree with you very much. We believe that we provide physiologic information, we provide imaging analysis, but that always must be used within the experience of the physician and the particular clinical circumstance of the patient. And we agree with you wholeheartedly in that way. And it's interesting, you touched upon a subject that many people are in the chat box are asking me about, and that is automated post-processing, automated results. You mentioned, I'd like to wrap up with this last question, but it goes to it touches upon something you discussed. The first is, what is the role, obviously, of automated post-processing? Can you see a way that it can be improved, maybe with confidence levels or with standardization? And you also mentioned the secret sauce, how different each manufacturer has their own way, their own algorithms, their own methodology of coming to some, I think, as you said, a definitive result within a probabilistic method. Do you think that we need more standards in the industry among clinicians? Something that we can all, some central standard that we can all refer to so that we have a common language?
Well, we do. So we have the language. We have this. So the language exists. In terms of the imaging parameters that we use in acute ischemic stroke are not, even though it's very complex in terms of how we get to those variables. The vocabulary of acute ischemic stroke imaging and therapy has been standardized. So we have the common data elements. Aspects is one of them. The core size, depending on what definition you want to use. Ticky reperfusion. The setting of, the various variables that we use in clinical trials exist. And they have been standardized and they've been used in trials from one to the next. In practice, it's a little different. And what matters is who is reading and defining those things. So do we need a standard set of those metrics? And yes, we do. I think we need not just one data set from one to the next, but we need a standardization in terms of what how we define the ground truth. If that ground truth is the aspects of a core lab that barely looks at the scans and just says, hey, everything's in aspects 10, well, then you have a problem. But if it is rooted in that expertise from a core lab perspective and it's been annotated properly, that's extremely valuable. So I think performance metrics, first of all, are very far removed from what is in a radiology report of an acute stroke image at any institution on a daily basis. The vocabulary does exist, but such data sets and standards to test software are also very important. So not just from an endovascular therapy standpoint, but to test those algorithms, and we need those. So we need the data to be tested, to test. We need the metrics. We need to trust those metrics. And not just say that that we just blindly accept them. One can argue that's what FDA needs. Regulatory bodies need the trust that things have been done properly and validated in that fashion. That being said, that's not how things are passed through regulatory hurdles nowadays.
Right, or even perhaps radiological or neurological societies to somehow bring together and create standards and comparative gold standards for manufacturers and clinicians to use.
Exactly.
Okay. I would love to continue. We're past our time right now. We certainly could continue this for another long while, but I think we have to wrap up right now. Dr. Liebeskind, I'd like to thank you very much for speaking with us today. I'd like to thank the audience for attending, and I wish everyone a very good day. Thank you. Take care.
Thank you so much, Adam. Take care, everybody.
Bye-bye.